Hello guys, very good evening to all of you. I am Dr.Amrit Nasta and today we will be discussing a very important but not the most difficult topics, that is pneumothorax. Pneumothorax is something that a lot of us have a little confusion about, but today when you listen to the concepts, the facts and the basic guidelines, you'll find it really simple and you will be like, bring it on. It will help you in your clinical practice also, it will help you in solving MCQs also. It can come as a case in the exam. So definitely this is something you cannot run away from. And it's not the most difficult things. It's just that we have that mentality that, okay, tension pneumothorax, open pneumothorax, sucking chest, closed, traumatic, spontaneous. A little confusing. We will simplify it. All right. We will go step by step and life will become very easy. So let's get started with the basic to understand what is pneumothorax. So whenever I teach, I always start with the basics so that you have a little understanding. I don't assume that you know too much from the start. So when I say pneumothorax, what does it mean? Pneumo means air, thorax means chest. So pneumothorax in real sense means there should be air which gets trapped or air which gets collected in the pleural space. Okay, air should get collected in the pleural space. That is the meaning of pneumothorax. If there is hemothorax, that is blood in pleural space. Pleural effusion is fluid, any kind of fluid in pleural space. Now, what is this pleural space? If you understand pneumothorax very comfortably. So let's look at the basic anatomy. Then things will get easier. So this is your trachea, the two bronchi, which will split into bronchioles, and these are your lungs. And the lungs have a covering. That covering, which is on the surface of the lung, it's a very thin covering. That covering is called as visceral pleura. So the pleura which is on the surface of the lung is the visceral pleura. Like you have visceral pericardium, visceral peritoneum. This is the visceral pleura. Outside the visceral pleura is the chest wall. So if I look at the chest, like there will be skin over here. Then there will be subcutaneous tissue, subcutaneous fat, some muscles. Then there will be ribs. All this will form the chest wall. The last layer of the chest wall is going to be the parietal pleura. Okay, that is the last layer. That is the parietal pleura, just like your parietal pericardium, parietal peritoneum. This parietal pleura also covers the lung like this. And do you know what is there between these two layers of the parietal and visceral pleura? It's not an empty space. There is a little bit of fluid in this space, little, maybe 5 to 10 ml. This fluid helps in the lung expansion. So the pleura will rub against each other because of the presence of this very little fluid, 5-10 ml on each side. So normally there should be no air in this space. If from outside some air starts collecting in this space, that will give rise to what is called as a pneumothorax. So now it becomes easy. Air is collecting between the parietal and visceral pleura. That is the meaning of a pneumothorax. Now, why does someone get a pneumothorax? Simple. We'll keep it very simple. Pneumothorax can happen for two basic reasons. One is it can happen by chance, by itself, that is spontaneous, or it can be in the setting of trauma. As a surgeon, I can tell you most of the times we see in surgical practice traumatic pneumothorax. In medical practice, you will see spontaneous pneumothorax. So spontaneous means what? In the absence of trauma, air came in the pleural space. Now, normally from where will air come? Air will come from the lung. Goes without saying, right? For some reason, if the lung had a burst, there was a burst in the lung, some part of the alveoli burst, and this air from the lungs breached the visceral pleura and went in the space between the parietal and visceral pleura. That will give rise to what is called as a spontaneous pneumothorax. Now, how will air from the lung go in the pleural space? Two reasons or two pathophysiologies. One is called a primary. Primary means it is happening without any lung disease. Some people, it is typically seen in youngsters, people who have Marfan syndrome. So usually it will be seen in teens and 20s. These are tall, lanky people, usually in their 20s, who have a family history of spontaneous pneumothorax, where for some reason there are blebs or bullae which are formed on the lung surface. So for some reason, these people are going to have bullae or blebs on the lung surface like this. They are like air-filled sacs. If one of these sacs will burst, it will throw the air into the pleural space. This is called a primary spontaneous pneumothorax. So young, tall, lanky males with Marfan syndrome, they are the ones who will get this. The other is called as secondary spontaneous pneumothorax. This is easy to understand. Secondary means there should be a pre-existing lung disease. Okay, there should be a pre-existing lung disease. And what is this pre-existing lung disease? Any lung cavity because of tuberculosis, necrotizing pneumonias. If there is a cavity in the lung and that cavity bursts on the surface of the lung, that will connect the lung parenchyma or the airways with the pleural space. So cavitary TB, cavitary tumors, these are the typical patients. So these are medical patients. They will be having TB of long-standing duration. Suddenly they become very breathless. You auscultate, there is no air entry. You think it is pleural effusion, but it could be a pneumothorax. So these are what are seen in medical patients. Surgical patients, what we are going to see are going to be patients who have a chest trauma. This could be a blunt trauma, penetrating trauma, or penetrating neck injury. How will neck injury give pneumothorax? This can happen if there is a tracheal injury. So the air from the trachea will leak into the pleural space or in the mediastinum. As anesthetists, you are going to see people in whom you insert a neckline. So when you are putting the neckline, if you don't put it USG guided, you may puncture the apical pleura and the air can enter into the pleural space. Positive pressure ventilation, also known as barotrauma. These are some of the causes of traumatic pneumothorax, right? So traumatic are what we see in surgical practice, spontaneous are what are usually seen in medical practice, right? So this is a basic idea as to why someone gets, but has to happen? Air has to enter either from the environment or from the lung into the pleural space. Now, what's the big deal if the air enters in the pleural space? Is it a big deal? So first things first, there are three pathological types of pneumothorax. The first is called as a closed pneumothorax or a simple pneumothorax, where there was a tear for some reason in the pleura. So let's say this is the visceral pleura surrounding the lung. For some reason, there was a little tear. And because of the tear, the air entered the pleural space and the tear stopped. So let's say there was a tear, maybe you were putting a neckline and there was a little tear in the lung, a little tear in the visceral pleura. Some amount of air entered the pleural space, but this tear automatically shut. So whatever air entered at that point of time is the only amount of air in the pleural space. Now, what will this do? How, depending on the quantity of air, it will cause that side's lung to collapse. There will be some amount of ipsilateral collapse, but it is variable. How much air entered, 5 ml, 10 ml, 50 ml, that much it will compress the lung. So this is a plain, closed, simple. One time air entered, then it stopped entering. The more interesting one is the open pneumothorax. Open means there is a continuous entry of air for some reason. It can happen in two ways. It can happen because of a tubercular cavity, which is burst, causing a communication. That is called as a bronchopleural fistula, where a large bronchial TB or a bronchial tumor burst, went through the lung, through the pleura, into the pleural space. So every time the person will breathe, some amount of air that will enter into that lung will automatically go into the pleural space. That is called as a bronchopleural fistula. This is going to usually be seen in the setting of TB or tumors, or it can happen after stab injury to the chest wall, which is what you will see in surgical patients.